efficiency as well. So we're also going to look at how to best document your oral agent compliance, those IV agent administrations, local destruction for pharmacy for unused, undispensed drug. Before I get into the content, which I think is super exciting, but I know it's been a busy week. We've had lots of speakers, some wonderful presentations. You all might be experiencing some presentation fatigue. I know I am. But I just kind of want to engage with the audience here a little bit. We've got a great turnout for the last day, so thank you for joining us. But how many, let's see, let's raise your hand if you are a pharmacist. Okay, just our main folks here in the front with ECOG, that's okay. Raise your hand if you are a clinical research nurse. Great, we've got a good number in the crowd. And raise your hand if you are a clinical research coordinator or a data coordinator. Okay, so a mixture of people. I think this talk is really going to be more centered towards nurses and clinical data coordinators. There is some pharmacy overlap there, and we will address pharmacy at the end. But I hope you can take away something from this and maybe learn a little bit today. Is anyone new to research or new to ECOG-ACRIN? Maybe you've never had an audit before. Any people who've gone through audits in the past, raise your hand if you've had an ECOG-ACRIN audit. Okay. So we've got some age-old troubadours there as well as some new folks. So with that, we'll get into it. We're going to focus on treatment today. Treatment really isn't one of the categories that we see a huge trend of deficiencies, but they obviously do occur sometimes. And when we do see these deficiencies, they typically fall into one of two categories. So the first being treatment intervention is not administered correctly. And what do I mean by this? It applies to your IV agents, oral drug agents, but it can also apply to imaging agents. So it could be the contrast that was administered or the imaging modality intervention. So we really look at this as your research intervention category. We could also see deficiencies in the category of treatment intervention not being adequately documented. Yes, we're going to talk about documentation today. I am sorry. I know this is something we hound into everyone, but as we always say, if it wasn't documented, we can't confirm that it happened. So we really, really want you to make sure you're documenting everything that you do, so you're getting credit for all of the hard work that you're doing day in and day out. So we'll focus on kind of how we review treatment at the time of the audit, but really specific to IV agent administration because we've had some questions about this when we're on site and then post-audit as well, although a lot of this can also apply to your oral agents. So we review cases to ensure that treatment is given in compliance with Section 8, which is your drug formulation procurement. We are auditors, so we see this pretty black and white, and we are very particular to the items that are discussed in this section. So please pay attention to your dose specifics, and I don't just mean nivolumab being administered 240 milligrams versus 480, but really look at the formula calculations there. So are you using the Calvert formula? How does the protocol want you to do carboplatin AUC calculations? Because even if you are administering commercial agent, if it's commercial agent that's administered as part of the research after the patient's been enrolled, we do want standardized administration. So that'll be talked about in Section 8. You also want to see if any of your IV agents have a total infusion time listed and a window. A lot of the standard of care agents are not given a required total infusion time. It kind of falls back to your standard procedures at your institution and what's standard overall, but sometimes you will see it. But with the research, study supplied agent, IND agent, you will see a total infusion time and window. We also want you to look at total concentration of your IV infusion. So nivolumab being 1 to 10 milligrams per milliliter, making sure you're fitting within that, and then checking your volume of infusion. Not every IV agent is going to have a maximum required total volume of infusion, but some will, like nivolumab is 160. We want you to pay close attention to sequence and timing of your drug administrations. So occasionally you'll have multi-IV agents that may be administered on the same day, making sure you're giving those in the right sequence or the right time between them. Or also they could be given multiple days, day 1, day 8, day 15, again, making sure it's the right sequence. We also want you to look at supportive medication. Oftentimes these are listed as recommendations, but please pay attention if it says must or required. As auditors, we really do look at that as must or required. So if you deviate from anything listed in this section, you are subject to, unfortunately, a deficiency. Something that's come up quite frequently is, when do I need to document start and stop times for infusions? This is a hot topic. So if the protocol, as I talked about, specifies administration to occur over a set number of minutes, as auditors, we say start and stop times must be documented. As I said earlier, this applies to commercially supplied agent and your investigational study supplied agent. If the protocol does not specify a length of time for the infusion, we do not require that you're documenting actual start and stop times for research purposes, although you probably still need to document these for your CPT codes and billing. If drug is being administered off-site, which doesn't happen very frequently, because typically for research purposes, all drug needs to be administered at your site or one of your participating sites. But if it does, it's the site's responsibility to retrieve the records from the administration site or service. So oftentimes this applies to those 5FU home infusions that are given, 42 to 48 hours. Now, we're not going to require really the specific start and stop times, but we do need to have records showing that this was given as per ordered, what the total dose was, what days it was administered. I also have a note on here regarding flushes. So flushes that are administered before and after your IV agent infusion should not be included in your total infusion time for research. Okay. Another hot item. So the CTMB audit guidelines are broad, and not every type of deficiency that we see at audit is delineated there. It could never be. This is nuanced. For ECOG-ACRIN, we've made our own interpretations of that, and we've really tried to standardize it upon our auditors. So infusion times, we've separated into what really classifies as a major versus a lesser deficiency. We used to be a little more stringent about this. I would say in the past maybe 1 year or so, we've eased up slightly. But for major deficiencies, we're really looking at infusions where there are significant or substantial variances from your protocol administered times. That's in that section 8. And what do I mean by that? So let's use nivolumab, for example. I'm probably going to use it a lot because this is a drug found in a lot of our protocols, and the protocols indicate it has to be given over 30 minutes with a 5-minute window on either side. So if you're infusing drug, and it's on the lower end of that spectrum, so it's less than 25 minutes, that is going to be cited as a major deficiency most likely, because we're affecting potential for adverse reactions in that patient and patient safety. If drug is supposed to be infused over a specific time and you're not recording start and stop times, we have no way of verifying that the administration time fell within that, so that would be a major. Also, if you're doing significant variances from the required time, so it's required 30 minutes plus or minus 5, and you're infusing it over 60, that would be a major, because we're not sure if perhaps the drug was ordered incorrectly at 60 or you weren't following the 30-minute ordering. Now, lesser deficiencies are all other deviances in time. So this is where we've eased up a bit, and I'm glad we did. So for infusions that might be, let's say you have 1 infusion out of 12 cycles of Nevo that is over. So you've got 1 at 45 minutes. We view that as a lesser deficiency. We're not seeing a trend in your overall infusion times. If you have several infusions that are just a few minutes outside of that window, that would also be a lesser. And then occasionally you might see a protocol where there is no window given, and we'll typically fall back to our plus or minus 5 minutes for 30-minute infusions, and sometimes plus or minus 15 for 60-minute infusions. The listed deficiencies here, just like the CTMB audit guidelines, it does not encumber every single deficiency that could be seen, but these are just examples. Okay, so next up is oral drug accountability and compliance. I think this gives us all many headaches. I know I've worked at the site level as well at IU Simon Cancer Center, large academic institution, multiple roles, and I've had headaches trying to make sense of the patient pill diaries and the total calculations and nothing, the patient narratives. We work with patients, and we ourselves are humans, so this is not a perfect test tube environment. Patients forget to fill out their pill diaries. They're scrambling to get them done right before their visit. There are errors. No one's a perfect narrator of the past. But it is important that we get the best historical record that we can, and things are documented to the best of our abilities. Most common issues when tracking pill compliance from medical records, you typically, forgetting to inquire and document if the patient is compliant. Has that patient missed any doses? Has the patient lost any medication? Did the pill bottle fall out and some fell in the couch? I mean, this has happened. There's infrequent to no documentation of checking compliance from patient visits. Or there's unclear, I'd say this is probably the most common, unclear or discrepant pill count documentation. So math errors or not accounting for each bottle when multiple bottles are being dispensed. We do have some common audit trends in oral drug compliance, really documentation trends. I've separated this into pharmacy deficiencies and patient case treatment deficiencies, although there is some overlap there. So for pharmacy, an example being a discrepancy in the number of pills returned that's being recorded on the DARF. So we'll review at audit that the CRA or the RN indicates pills have been returned. However, pharmacy is not documenting any returned pills on the DARF. This could be for various reasons, but to us, it looks like drug was never returned to pharmacy. There could also be discrepancies in the date of return, and there's a gap in that chain of custody. So the RN or the coordinator will be documenting a date, and we'll see when the patient was seen in clinic, and then somehow the date the patient returned the drug to pharmacy and the patient return date is different. So what happened? Where was drug? Was it hanging out on a shelf in the clinic? We don't want that, but oftentimes it's just data documentation errors. For patient case treatment, we do identify some trends in unable to verify drug compliance. So we'll see lots of discrepancies between the patient pill diary, the return number of pills documented, and the data entered in RAVE. If we can't figure out a narrative, if they don't all paint the same picture, it's hard for us to verify what that actual drug compliance was. We also see inabilities to verify drug compliance if the protocol requires patient pill diaries and none were completed or submitted. Now, we know this does happen sometimes because patients can be non-compliant, but in the case that that's happening, it would then fall onto the nurse or the coordinator to have a conversation with the patient and try to get the best narrative that they could. Are you being compliant? Are you taking your drugs? Did you miss any medication? And then documenting that in the record. We also see this somewhat frequently, the total dose being inaccurately reported within RAVE. So you're doing everything correctly. You've got the patient pill diaries, you've counted the correct pills being returned, the patient was compliant, maybe not, and then the person who's entering total dose in RAVE has math errors, or they're not accounting for how many pills were actually distributed to the patient at the beginning of the cycle. So just some best practice here. It's pretty simple. You may have a little bit of a different best practice that works well for your institution, but just some gentle, kind of easy reminders. So prior to a new dispensation of oral agent, please always ensure that the patient's returning leftover drug and a pill diary, if a pill diary is required. Document the date of return and the number of pills returned. You want to be comparing the number of pills returned with the patient pill diary entries. We often see these are discrepant and it's never discussed with the patient in real time. So if there are discrepancies between those, talk with the patient. Try to make the most sense of it while you have the patient in the clinic and while it's fresh on your mind, because 2 months down the road, the patient isn't going to remember what actually happened, and you're going to be so busy doing the other 1,000 things you have to do, you're not going to have time to review it. If the patient diary is not returned or not required, like I said, perform that verbal confirmation of adherence. And we really, ideally, we don't want you just asking the patient, have you been compliant with your medications? I think this is too broad, and we often don't miss dosing inaccuracies. We want you to be asking the patient, have you been taking one pill in the morning and one pill in the evening? Because sometimes we'll find patients are confused on what their actual dosing should be, and they may only be taking one pill per day, and then they're getting underdosed. And this is the time when we identify that, we can re-educate the patient and making sure they're getting the full amount of medication they should be for these protocols. And then you also want to make sure you're returning that leftover pill bottle, if it is returned, I know sometimes they're not, to the pharmacy same day. So we've got that chain of custody. We don't have pill hanging out on a counter in the clinic overnight, and so that pharmacy can do their job as well. So documenting patient returns on the pharmacy, I think this is pretty straightforward, but just a couple reminders, and there is one little quirk with PMB. So you're going to be getting that bottle back, hopefully same day, and you want to confirm protocol, patient study ID, bottle lot number, and dispensation date, so you're recording the returns on the appropriate line, counting the drug, and then filling out the oral DARF. Something weird about the oral DARF and the PMB's requirements, they don't want 0 being recorded for the quantity patient returned. So if the patient's returning an empty bottle, please just indicate the date the patient returned and leave the quantity patient returned blank. Charted, yes, okay. So using oral compliance to calculate total dose. A couple reminders here. So when there are discrepancies between your pill diary, patient narrative, and the number of pills returned, and you're not really getting a clear idea, you're talking with the patient, it's still unclear, we want you to use the physical number of returned pills to calculate the total dose. This is your golden standard. If you don't have physical number of returned pills, then you can try to piece together the patient narrative and the pill diary. Another thing to remember, often bottles contain more pills than are required for the cycle. Patients for oral drug are typically on 21 or 28 cycles, but these pill bottles come oftentimes in 30 count numeration, so 30, 60, 90, to account for patients' scheduling. The protocols also allow for 2 to 3 days leeway on coming into clinic, so we want to make sure that patient's getting continually dosed. I do have a total dose calculation practice problem. I don't think we're going to have time to go through it, but I can talk about it a little bit. So let's just say the patient comes in, he returns 1 bottle of crizotinib. It's 25 milligram tablets they contain. The bottle of return has 4 pills. The drug order is to be taking 25 milligrams BID. Your cycle length is 28 days, and each bottle is dispensed with 60 tablets. Today he returns for cycle 2, day 1, and states that he accidentally took a pill before coming to clinic. Okay, it happens. They're still on continuous dosing, but you do need to take that into account when you're calculating total dose for what you are entering into RAVE. So when you're calculating that, you want to first think about your expected number of pills taken. He should have taken 56 tabs for the 28 days. The expected number of pills to be returned is 4. The patient did return 4, but remember, he also took an extra pill. So your expected total dose would be 14,000, but there is a deviation from that. So since the patient took 1 extra pill, it actually means he only took 55 pills rather than expected, and your total dose is 13,750. So documenting dose modifications in RAVE. Oftentimes you don't have 100% compliance to your protocols. Things happen. There are side effects, complications, there are dose reductions, there are scheduling delays, there's patient non-compliance, whatever it may be. We want to make sure if your RAVE form is asking for dose modifications, you are tracking everything that happened for that cycle. So types of dose modifications, I think sometimes people maybe assume that this is only for a dose reduction. But it can be multiple different categories. So it could be a dose held you need to record, dose delayed, dose missed, dose being discontinued early, or dose reduced. And there are a lot of reasons, as we talked about, your side effects, your complications, patient refusal, non-compliance. This would just be where you're entering any days you know are missed on the pill diary or where the patient forgot to take medication. So we've got scheduling delays. You couldn't get the patient into clinic on time because it was Thanksgiving or Christmas. Dosing errors. This includes dosing errors from the clinic. Perhaps the initial drug order was incorrect. Hopefully that doesn't happen very often. Or a dosing error by the patient, like we talked about. So the patient's accidentally only taking one pill instead of one pill twice a day. And then the alternative therapy in the second primaries, that would be what you're entering when the dose is being discontinued. If your reasons for dose modifications do not fit into any of these categories, oftentimes RAVE will let you type in other, and that's where we want you to be really specific on the reason as to why the dose modification or deviation happened. So I have just a snapshot from EA 4181, acalabrutinib. And we'll go through some of the lines here, just so you know you're making sure you're entering data appropriately and how we want it. So the prescribed daily dose, that's day one of the reporting period. So if the patient's on the initial dose of drug, which is 200 milligrams and nothing's changed, we want it to be 200. But if the patient's coming in for cycle 2, day 1, and they were experiencing toxicities from cycle 1, and the physician decides a dose reduction is going to happen on day 1 of cycle 2, we want the dose reduction dose here. So if they're being dose reduced to 100, that's where you would put it here, and you would enter your dose modification reason on the log line at the bottom. Total agent dose, sometimes people get confused with this, but it means the total dose given throughout the cycle for every single day of treatment. So you want to make sure you're adding that up appropriately. This is where you'll be indicating what's been returned, the pill diary, the pill bottle, and the source of the pill count. This is actually wrong. It says patient pill diary, but the patient returned their pill bottle, so we'd want that source of the count to be the pill bottle. And then, yeah, just making sure you're doing all of your dose modifications, and you may have multiple, so typically RAVE allows you to create additional log lines. If you have any questions about how dose modifications, how they should be entered, you can always reach out to your data management team. You can email Ask E-A Audit, we can help you with guidance there. When you're emailing the data management team, there are the email aliases. So it all follows the same format. It would just be the protocol followed by team at ECOG-ACRIN.org. So for this, it would be EA 4181 team at ECOG-ACRIN.org. Okay. So now for just some quick reminders for pharmacy. When your study closes, the magic number is 90 days. You have 90 days to do something with that drug, and it could be various things we'll talk about. If you still have patients who are receiving treatment at the date of study closure, you have 90 days until that last patient on trial has received treatment. So when the drug closes, you can be returning the agent to the PMB utilizing the NCI return agent form. This is primarily what you're going to do. It could be transferred to another eligible NCI protocol within your group. This could be transferred between different investigators, but just make sure you're sending that form out to the PMB and you're getting authorization for the transfer, and you're not making the transfer preemptively prior to receiving that authorization. And then occasionally, drug can be locally destroyed per institutional policy with PMB permission. This isn't going to be for every drug. There are some parameters for this. And when I talk about local destruction in this setting, I'm only talking about unused, undispensed drugs. So this is a drug that has never left the pharmacy. It hasn't been given to the patient. This isn't for the return pills. A couple considerations for local destruction of this unused, undispensed drug. This has to be requested each time you do it. So it can be requested for dangerous goods or infectious agents, clinical trial sites located outside of the United States, or when otherwise directed by the PMB, or if specifically listed in your protocol, Section 8. Local destruction must be requested by a specific form, which is on the PMB website. And if it is approved, PMB will send an authorization letter. You cannot destroy drug until the authorization is received. Drug must be destroyed. You have 30 days of receiving authorization. So take this into account when you're on that 90-day window. And then after destruction has occurred, the investigator has to sign the authorization letter and return it to the PMB with supporting documentation. More documentation. We had a couple questions on documenting local destruction on the DARF. And this can vary slightly depending on what method you're using. So what we would look for at the time of audit, if your approved local destruction policy is to destroy unused, undispensed drug on site and you've received PMB authorization, please enter the actual date of destruction. If your approved local destruction policy utilizes a reverse distributor and this third-party service to destroy the drug for you, we do not require you to put the actual date of destruction of that drug because you're not going to know it. It's out of your hands at that point. We would require you just to enter the date of transfer. So we have that clear, again, chain of custody of the agent. This slide just has some resources. I know you've probably seen this in some of Josh's talks. Really helpful, especially if you have new pharmacy staff, which we don't have any pharmacists apart from our ECOG people, but remind your pharmacy and new staff there that there are these wonderful educational videos that the PMB has created that are so helpful in knowing just kind of how to play by our rules so you're being compliant. And then we also obviously have the CTMB audit guidelines and some other education material. This is just a slide reminding you of your lovely audit team. I know audits can be really stressful, laborious, time intensive, but from ECOG-ACRIN's perspective, we're partners here. We want to work with you to help make sure that you're conducting the best possible research, having the best data, you have source for all of the hard work that you're doing, and just educate you along the way and identify any areas of weakness, because these protocols are challenging. There are multiple pages, there are hundreds of assessment time points. We know perfection isn't going to occur. We're humans, there is error. It's sometimes impossible to meet all of the criteria. But we do audit to perfection with some understanding. So there probably will be deficiencies, but hopefully they're minor. So now I don't have another slide saying questions, but we're going to open up the floor to any questions from you guys over the content that's presented here today. No? Michelle? I can always count on Michelle for a question.
Thanks, Kayla. So I did have a question, and when you were talking about if there was a discrepancy between the pill count and the medication diaries, there used to be a period of time where there were incidences of there was potentially overfill in the bottle. So there were more tablets in the bottle than maybe 28, right? And you really didn't know that. I mean, at our site, if we get a bottle, we just turn around and dispense that same bottle to the patient. So sometimes it's not being dispensed by a pharmacist per se. So if there's overfill in the bottle, does that still happen at all? Do you ever see that?
Yeah, frequently the bottles do not have exactly the number of pills for the cycle.
Right.
So there's often a few more in there to account for if the patient's not coming in at exactly day 21 or 28. So we would just urge you to work with your pharmacy or the drug shipping orders to know what the initial count is in that bottle.
Right.
Yeah.
But I like your comment that it's the physical count that is.
It's the physical count. If you have it, sometimes you don't even have that. So
okay,
it's challenging, I know.
Thank you.
You're welcome. Any other questions? Okay, and there's one in the back too, so.
Thank you, Kayla. I just had a quick question. We were having a debate about this at our site. For example, with carboplatin in the calculation, when you guys come in and audit, do you want to see our work for that calculation, or do you do the calculation and just make sure that it matches what you came up with?
There are, this may vary by auditor. I know there are some auditors who would like to see your calculations and that you're doing those in real time. Ideally, that's what we would want the source to show, but we can also reverse calculate that based off of the labs that were on that day.
Hi, Kayla. Thank you for such an amazing talk. And I just want to let you know, too, even though the pharmacy committee members couldn't be here in person, they were really looking forward to this talk, and they are going to watch the recording, and we might even broadcast it at our next meeting. So they all, are chomping at the bit for this information and are sad they couldn't be here today. But my question is, I wanted to ask a question like on behalf of the pharmacy committee. So for the sequence of the drugs, we try to get those in the protocol because we review the protocols, and I go by the NCCN guidelines for the sequence of the drugs. So I've always been taught that in a protocol, you would give, from first to last. So if it's written first, you give it first. If written second, you give it second, that type of thing. So I'm wondering, do the auditors take that into consideration? Are they looking at it from the same lens that I'm looking at it, whereas first to last?
We do. And sometimes in the protocols, you also specifically outline what is first to last as well. And it's not just when the drug's listed, but yeah, we look at it the same way you do.
Okay, great. Yep, just wanted to clarify that. And also, I really like what you said about the infusion times, and that if the infusion time isn't written specifically in the protocol, that you don't need it on audit, which is really interesting to me as somebody who's involved with protocol development. So if it's a standard of care agent, like say it's pembrolizumab and we give it over 30 minutes, we're always going to give it over 30 minutes. Would you recommend just leaving infusion times out completely?
If it's a standard of care agent.
And we can
Yeah.
indicate, give as standard of care at your institutional practices.
Yeah, I think so, because that would ameliorate a lot of deviations that we feel like we have to cite because it's deviated from what's written in the protocol. And then we can just focus on research administration.
That's awesome.
Agents.
Thank you so much. Yes, because I know a lot of sites have their own SOPs around, like I used to work at Penn, and carboplatin could go over 30 minutes at one site and 60 minutes, even at the same institution. And it's physician preference sometimes.
As long as the protocol and your study chair is okay with that being physician preference, and then we're getting a better idea of how these drugs would be used at actual beyond research and standard of care, because there is variance in institutions, we'd be fine with that.
That's awesome. Thank you so much.
You're welcome.
I have a question that sort of adds on to what she said about leaving it out, and I thought of it when you were talking, and I'm assuming the documentation to which you're referring is the documentation that was performed by the infusion nurse about the start time and the stop time. And I don't know how we'd leave something out because everything's documented in Epic at our location. So do you know what I mean? If you were providing the source for a drug that was given as part of a cycle, the standard of care drug is going to be in there too.
Yeah, it should be, but you'd be surprised occasionally we don't have that source documentation in the EMR. It's not present. The site's unable to provide it. They'll say, well, we used a pump that was set to 30 minutes or 60 minutes, but we don't have actual start and stop times. We just do the pump. So it does happen occasionally, but yeah, more often than not, we can verify everything in Epic.
I may have misunderstood what you said. I thought you said, should we just not include that for the auditors?
Oh, no, you should include that. We want to see start and
Okay.
stop
All right,
times. We do.
Thank you so much for clarifying that, because I'm like, well, how would you not include that? It's all in Epic, it's all together. Thank you,
No,
that
just
makes sense.
in the protocols, so we can lessen the amount of deficiencies. That would be great. Yeah. Okay, anybody else? Any other questions or comments? Okay, yeah.
Hi, I had a question about the study calendar. So a lot of our patients, sometimes they'll lose the calendar or they forget it at home and things like that. Is it okay, like if the patient comes, they forgot it, we give them a new one, they try to fill it out, it kind of gets tricky, you don't know if they really are putting in the right amount.
Yeah.
Is that okay?
That's okay. We just wanted you to do things to the best of your ability and due diligence. So just giving them a new calendar, having them fill it out to the best of their ability, that's okay. And then if they have the completed one at home, reminding them to try and bring that in at their next visit, but it doesn't always happen, I know. And I do want to say for the oral drug compliance, right? We know patients aren't always compliant, and yes, that might be a deviation from what's required in the protocol. Maybe they've missed a drug, they aren't getting the full total dose on a day. But we won't always cite that as a deficiency at the time of audit if you're documenting appropriately. So we can see that you've identified that the dose has been missed, you've re-educated the patient, or you've tried to extrapolate to the best of your abilities what the actual dosing compliance was. As long as it's documented and we see you're making these attempts with the patient and you're trying to do the best you can to kind of put back together that narrative, that would not be a deficiency at audit. So that's something to take into account as well.